This program is brought to you by Rapid, offering expert services and software solutions related to quantitative imaging and dosimetry. Explore more at rapiddosimetry.com. Hi, folks. It's Dennis, the producer for this podcast series. In recording this episode, we experienced some technical difficulties. We had to re-record lines for George, as well as experienced some audio corruption. So if you hear some audio quirks, we apologize. We especially apologize and thank Dr. Anna Keiss for her time, but we still think this episode stands very well on its own merit. And thank you as always for listening.
We are absolutely delighted to have on today's podcast Dr. Anna Keiss. The first question we ask is, what is your definition of radiopharmaceutical therapy?
My definition of radiopharmaceutical therapy is a radioactive targeted therapy usually used for cancer that is most commonly systemic and can be conjugated or unconjugated.
So when you say systemic, you mean injected through the
bloodstream.
Sort of like chemotherapy.
Yes, we have agents that are not injected into the bloodstream. Well, so it can be injected into the bloodstream or taken orally. Either of those are considered systemic. So radioactive iodine is a systemic therapy that's given orally, and lutetium PSMA-617 is a systemic therapy that's given intravenously. And then there's some that are given through the bloodstream, but not circulating in the entire bloodstream. So that would be like TheraSpheres, which is liver arterial directed microspheres, and that's given through specific catheterization by interventional radiology of only the liver circulation.
Yeah, geez, that's a really detailed answer. But especially like you mentioned of radioiodine therapy, I believe that's probably the one most commonly known to a patient population. And it really is radiopharmaceutical therapy. And the last two that you mentioned, the microsphere injections, are FDA approved and seem to be really successful. Okay, so let's see. You got your bachelor's in chemical engineering at UV Charlotte, MD, PhD at Duke, internal medicine and biomed engineering. And then you were a resident at Sloan Kettering for about a year, it looks like.
4, technically. Although one of those years, I was doing my postdoctoral research with Marty Pomper at Hopkins. So I was really both MSK and Hopkins that year.
That's where I sort of grew up, at Sloan Kettering. You were there, I guess, 10 years after I left.
But people were still talking about you.
Oh, okay. Tell us a bit about your journey.
So I always loved science and engineering and math, and had 2 parents that were doctors. My dad is an emergency medicine physician and my mom's a pediatrician, and they encouraged me to consider computer science or engineering. And I went to engineering school, and then of course came right back to medicine and did biomedical engineering and medical school combined in the MD PhD program, where my mentor was Mark Dewhurst at Duke University, who does a very broad range of research from imaging to the tumor microenvironment to drug delivery. And I was working on imageable liposomes that had MR imageable contrast agents inside them along with the drug. And that is a nanoparticle that can be used for manipulating cancer therapies to target the tumor more effectively. So basically, during my PhD, I was already kind of in the field of theranostics, I would say, because it was imageable, targeted systemic therapy, but not radioactive. So theranostics, but not radiotheranostics. And then I completed my PhD, and my mentor had a joint appointment in radiation oncology. And that's where I learned about the really nice intersection between patient care and technology and basic science in radiation oncology as a field. And so I joined the residency program at Sloan Kettering and heard about radiopharmaceuticals and had my first exposure as a resident there. We had some cases of samarium and strontium and Xofigo. Also, I was observing some cases of MIBG. I heard about some of the labs that you were in at Sloan Kettering that were developing new radiopharmaceuticals. And then my husband got his first job out of grad school Hospital in Baltimore. So I turned my attention towards Maryland and met Marty Pomper, who welcomed me to join the lab. And that's where I really first became exposed to radiopharmaceutical therapies. Dr. Pomper, as many who will have interest in radiopharmaceuticals know, is sort of the godfather of PSMA-targeted imaging and therapy and has 30 years of history working on targeting PSMA. He's the inventor of Pylarify, which is DCFPYL, the F18 PET imaging agent that we use every day in clinic, and also has invented several therapeutic agents. So I did work with him and you. I met you then too in about 2013, looking at the microscopic distribution and toxicities and effects of alpha emitters targeted to PSMA. We had one of the first publications on translational work with PSMA targeted alpha emitters. And then I joined the faculty and had initially just clinical trials in radiopharmaceuticals. And then over the past few years, we have had a building practice of clinical lutetium PSMA-617 and radium-223 for prostate cancer, along with our clinical trials and all of our collaborative dosimetry work.
Great. And the PSMA-617 is known commercially as PLUVICTO.
So PLUVICTO is the most commonly used radiopharmaceutical in clinic right now. I just finished giving a patient a dose right before I logged in, and it's given once every 6 weeks for up to 6 cycles, so up to 9 months of treatment. It's currently given at a fixed dose of 200 millicuries or 7.4 gigabecquerels. You currently only use it as a third-line treatment, really last-line treatment for metastatic castrate-resistant prostate cancer.
Patients, they've exhausted every other treatment option.
Usually after chemotherapy, which is a taxane-based traditional more toxic chemotherapy, and then also androgen receptor pathway inhibitors, which are more novel hormonal agents like abiraterone and enzalutamide. And that's already after they've been on androgen deprivation therapy continually, usually for years. So this is third line after the androgen deprivation therapy is no longer working on its own.
What did patients receive at this point in their course before PLUVICTO?
Most of the time they receive docetaxel as the treatment right before PLUVICTO.
I mean, what's interesting about this conversation is that you're a radiation oncologist, and all of this sounds like medical oncology type stuff. It really highlights, I think, the multidisciplinary aspect of this particular field.
Yeah, I mean, on Friday mornings, I also join the prostate medical oncology rounds where they run the patient lists and all the trials and learning a lot from them. And then also participate in their research and strategy meetings on Mondays.
Can you tell us a bit about the impact that PLUVICTO has had relative to what the docetaxel that was the option before?
I think the simplest way to explain the difference is this past summer, my patients who had been on taxane chemotherapy and then switched to PLUVICTO started scheduling summer vacations instead of hospice. They felt really well in between cycles. One of them went to the south of France. Another one did a bucket list trip to the last U.S. ballpark that he hadn't visited, and really just able to enjoy time with their families. What more could you ask for in a therapy?
Right.
Yeah.
I mean, as you know, as many will know, I get emotional, so I'm going to try and tamp that down a bit. Okay, so that sounds great. It's made a huge difference, I guess, compared to docetaxel.
Yes, patients, some of them, were really, really fatigued and unable to do much while on chemotherapy. And some of them just only had 1 or 2 doses of docetaxel before they were screened for PLUVICTO. Not screened, but before they underwent PSMA PET imaging and switched treatments.
So yes, that's a great anecdote, but is that the general sense that you feel is pretty common?
Well, some patients do really well with tolerating the taxane chemotherapy. And, I have a broad range of patients on treatment with PLUVICTO, range from having had only 1 cycle of taxane chemotherapy and not tolerated it and had progression to one who had 15 cycles of taxane chemotherapy because it was working well and they were feeling pretty well on it. So it's highly variable.
I guess the patient's response to previous treatment determines when they arrive for PLUVICTO.
I will say the ones who've had 15 cycles of prior taxane chemotherapy, their bone marrow reserve is not the same as those who have had minimal chemotherapy, because there's some lasting bone marrow effects from the cumulative prior therapies.
So it's 6 cycles of PLUVICTO. Do most patients make it all the way through the last cycle? You've indicated that some have potential marrow issues. I'm wondering how that plays into all that.
Yeah, a lot of patients need to stop early, either due to progression of disease or due to marrow suppression. I don't have the stats on this on the tip of my tongue from like the VISION trial, but my sense clinically in our sort of real world practice is that at least half have to stop early for one of those reasons.
Again, just to make clear, this is probably the first viable FDA-approved agent for metastatic prostate cancer.
There's other FDA-approved agents. This is the first PSMA-targeted agent. And I would say of all of the treatments for metastatic prostate cancer, it's one of the least toxic and most effective.
And I think that's a hallmark of radiopharmaceutical therapy. But before that, can you tell us the difference between PSMA and PSA?
So these are confused often because the acronyms are so similar. PSMA is prostate-specific membrane antigen, which is a transmembrane protein that is expressed on the surface of prostate cancer cells, about 1,000-fold higher than regular prostate cells and even more fold higher than many other tissues in the body. So that is what PLUVICTO targets. It's what the new PET scans highlight. And PSA is a blood biomarker of prostate cancer that is secreted into the bloodstream. And that sounds similar, but it's a completely different biologic entity. And that is still what we use as a marker of response to PSMA therapy often is for any therapy for prostate cancer. The number one way to assess the treatment response in a sensitive way is to test the PSA in the blood.
So you mentioned the PET scan a couple of times. Tell us a bit more about that and what does it do?
PSMA PET scan, there's 3 FDA-approved versions of it. The one that we use that was invented at Hopkins and has the best resolution is F18-DCF-PYO. Essentially, it's a whole body scan of the tracer, a very small dose, like 10 millicuries compared to 200 millicuries that we give for lutetium PSMA PLUVICTO. But after giving 10 millicuries of DCF-PYO, an hour later, you get a whole body scan and you can see the areas of brightness are areas where the prostate cancer has spread or is located. It's used at every stage of prostate cancer now, not just for screening for PLUVICTO. It's used diagnostically for most patients with prostate cancer at the time when they're initially diagnosed or at the time of recurrence if they've had a PSA rise after a prostatectomy or irradiation to the prostate. It's also used often during the treatment course at times when the traditional imaging methods like CT or bone scan are not sensitive to changes in the tumor status. The sensitivity and specificity is so much better than CAT scan and bone scan. It's hard to even describe, but it changes almost every patient's treatment management. So if I see a patient who has their PSA rising after a prostatectomy, they could have a PSA of 0.2, and the PSMA PET scan can show a recurrence in the prostate bed. And then we know exactly where we need to treat, and we can sometimes avoid treating the pelvic lymph nodes or adding hormone suppression or other more toxic treatments because now we can see what we're doing. It's really been transformative, amazing technology for prostate cancer.
Wow. Okay. So just to get into the weeds a little bit, it's different radionuclides, right? In one case, it's lutetium, and in the other case, it's the familiar F18 that patients get for FDG glucose.
So F18 is a positron emitter. It's designed and suited for imaging with PET, prostate emission tomography, and it is not emitting a therapeutic type of radiation. So lutetium is a beta emitter. It also emits gamma emissions, and the therapeutic portion of the decay spectrum is the beta emissions from the lutetium. So that's electrons coming off of the lutetium after it's been bound to and incorporated into this prostate cancer cell. So it gets internalized, and then these electrons are coming off of the lutetium from inside the cancer cell and causing DNA damage, which you don't get from the F18. And then, of course, there's the up-and-coming alpha emitters like actinium-225, where, again, the molecule is internalized in the cell, hopefully trapped, and you have much stronger alpha particles, which are much larger and cause much more DNA damage than the beta particles do.
All right. So we've covered, I think, a lot of the current state.
Hopefully, in more like the 5-year range, we will have FDA approval of PSMA-targeted alpha emitters. And within 10 years, I hope that we have radiopharmaceutical therapies for every major type of cancer. That may be a little bit optimistic, but I think with the pace of development in industry, in terms of the number of drugs being developed and the amount of investment and in this area, that's a real possibility that we will have radiopharmaceutical therapies available for most cancers.
Well, I'm really glad that you're optimistic. I share your optimism because I do really think that this fundamentally different approach to treating cancer will have a significant impact. Okay, so let's move on to another question. People ask me what I do for a living, and for me it's kind of complicated to answer them because it's more research than anything very tangible. So what do you say when people ask you what you do for your job?
Well, I usually say I treat cancer with radiation, and that keeps it kind of broad. And then if the person wants more detail than that, I explain that I'm a radiation oncologist and I use external beam radiation, which is large linear accelerator machines that give beam radiation, but that I also use radiopharmaceutical therapies, and that we can treat almost any cancer with radiation using one or both of those forms.
That was a nice, clear-cut answer because you've encompassed the idea of external beam and the radiopharmaceutical therapy part. Can you just very briefly tell me about how new drugs get FDA approved and what the development process is to make it to the clinic?
So in the process of drug development for cancer, most cancer drugs start out at that point, given as one of the latest lines of treatment, and they move through different trials. Phase 1 trial, they escalate the dose to look for the tolerated dose. Phase 2, they look at the efficacy, like the tumor responses. And then in phase 3, they really power it to show improvement in a specific endpoint versus the standard of care. And then the standard of care in the US is often defined by the NCCN guidelines and other large group guidelines. And the line of treatment is sort of like the order in which you do things. So you first test a new drug as last line or third line or, not upfront because you're trying to see whether it's safe. And when there's not other treatment options, then the benefits outweigh the risks, even in that situation. So then once you've established that the benefits outweigh the risks and it's FDA approved, you want to give it to a lot more people, and you want to give it when it will be most effective in terms of their cancer journey, which is usually not the last line or third line. So there's many studies going on right now, or even some already completed, looking at PSMA-targeted therapies earlier in the treatment course.
We know that the FDA has struggled with placing absorbed dose limits on tissues that they consider to be tissues of concern that could be dose limiting. They would use external beam radiotherapy to help guide their decisions and the numbers they put on the dose to these tissues. So related to all that is this effort called RPT Tech. Can you tell me a little bit about that?
RPT Tech stands for radiopharmaceutical therapy, normal tissue effects in the clinic, and it's sort of a similar naming structure as several other collaborative groups that have helped set dose limits for tissues exposed to radiation, typically from external B radiation, so safety and dose limits. So the idea of RPT tech is to use dosimetry from SPECT imaging and to help define the dose response relationships, particularly for normal tissues like bone marrow and kidney, such that we can have specific understanding of dose limits and safety considerations for specific radiopharmaceuticals.
Yes, and in fact, you've highlighted one of the major advantages of radiopharmaceutical therapies, specifically that we can image and understand the absorbed dose, basically the mechanism of action for this kind of treatment modality.
So my question is, you've been doing amazing work on alpha emitters and dosimetry for, I won't say how many years, but a good number. What are you most proud of that you have done so far? And, how do you think we can use it best?
It's a great question. Let me first say that longevity has been key. A lot of people have moved on, and people have looked at the work I've been doing and have basically said, okay, great. When is this really going to be used? And it's just so wonderful to suddenly see it being used, and more to that, to see so much interest in startups and so much money coming into the field. The thing is, when you believe in something, at least I tend to stick with it, and I'm glad I did. I guess what I'm most proud of is not abandoning the field and sticking with it.
It's always a pleasure, George. Thank you so much for inviting me.
Okay, great. George, for this episode, you had to re-record some lines towards the end of this episode. We normally have a recap about our guest, but I can see you're incredibly tired. So with that, I would like to thank Dr. Keiss, especially for her patience for this episode to come out. We've been sitting on it for a good couple of months. With that being said, I would like to thank Dr. Keiss and thank you, George, for this episode, and we'll see how we do the next episode.
Okay, yeah, thanks, producer.
Okay, bye, Dad.
It's always fun to do these things with you.
Yes, and it's always lucrative. I mean, yes, and it's always really fulfilling to do them with you too, Dad.
And it's all about fulfillment.
It's all about fulfillment.
Okay. Bye. Bye, my son.
This has been the Radiopharmaceutical Therapy and Dosimetry podcast with Dr. George Sgouros. Produced by me, Dennis Sgouros. Executive produced by Dr. Michael Ghali at Rapid Dosimetry. You can rate and review this show on Apple Podcasts. Got a question for George? Or interested in Rapid Dosimetry's products and services? Email us at dsgouros@rapiddosimetry.com. And if you haven't already, please subscribe wherever podcasts are downloaded.